Welcome, welcome, everyone who's calling in and joining us today. We're glad that you're here. We still got folks coming in the webinar room, as it were, so we're gonna give it maybe a minute or so that everyone can be with us here as we start. But if you're already here, would love to know, just put it in the chat, are there 3 words that describe or define what you're most proud of as a professional? Just share it so we can celebrate the skills and the strengths that you're bringing. Team you work with, wonderful. Helping other people, love that. That's why we're all here. Connecting with others, wonderful. Continued growth, love that, Alicia. Helping integrity, ethics, and knowledge. Helping people, coaching staff. Ooh, the power to empower. Addressing those gaps, improving patient lives. I love that. That mentoring, teaching the next generation, seeing that change, making that change happen. Oh, committed to improving healthcare for people with serious mental illness. Flexible, resourceful, and humor. You sound fun to work with. Changing perspectives. Yes, working in population health. I know I love it. Bridging the gap. Wonderful. Keep them coming, folks. Connecting community environment. The judge said it was pharmacy school. I'm going to say, we appreciate honesty and transparency here today. Full disclosure and transparency. Yep. Focused health navigation. Love that. Wonderful. Growing from good and bad experiences. Yes, it's a journey. Adaptable, innovative, and persistent. I love that, Wendy. Perfect. Letting patients know they are not alone. Yes, and actually that, I think some of our presenters today might touch on that a little bit with why screening tools are so important. So it looks like folks are still trickling in, but want to honor everyone who came on board early. Ooh, improving health equity and equality for all, being able to lead mobile COVID vaccination clinics. Wow, Tara, thank you so much for that important work. Keep them coming, folks. I love this. Feel free to engage and congratulate each other for all being in this field together in the chat. Let's go ahead and get started, and folks can come on board as they join us. So welcome everyone on this Thursday afternoon or morning for some of you, depending where you're calling in from, to our we've got to ask that too webinar. We're focusing on navigating the tricksy world of preventative screening and integrated care today. Next slide, please. It's me. I'm Kirsten Potterbush. I work in the integrated care space. Some of you might be familiar with me from my work with some of the initial PBHCI or primary care behavioral integration grantees. But I really value being a part of this field and getting to work with colleagues like Maia and Deb all day. Next slide, please. So a little bit about us. We're PCDC. We believe in addressing health equity. And so we do that via community investment because we're a CDFI. We do that via training, technical assistance, consulting around integration and billing for integration, talk about Trixie, and also advocacy and research. So really we're looking to do what's needed to help maintain and bolster our safety net services. Next slide. Big thanks to SAMHSA and to our partners over at the Center of Excellence. And of course, the views, opinions, and contents expressed in this presentation do not necessarily reflect the views, opinions, or policy for CMHS, for SAMHSA, or for the U.S. Department of Health and Human Services. Next slide, please. So this is what we're doing this year. And if you've already been with us for a little bit of the journey, you'll know that this is our second webinar. This year, we're really focusing in on the nuts and bolts of what's going to make it a little bit easier, hopefully on your end, to operationalize integration within your space. Next slide, please. So just want to learn a little bit about you today. Want to know where you're coming from so that we can, do a little adaptation on the fly to ensure that the information we're providing is relevant. So just give it, probably 30 seconds and let us know. Maybe you're in a primary care setting, behavioral health, you're already in an integrated care setting. And also, if that question about where you're working primarily doesn't fit you, if you're an other, let us know in the comments. We've had all kinds of phenomenal folks who we just didn't capture what you did on this poll. And we still want to know you. We still want to celebrate. Yes, CCBHC project director. Yes, CCBHCs. So yeah, tell us who you are. Tell us how you're in this space making a difference. Never want to limit people to check boxes here. Ooh, health equity specialist for Medicaid agents. Thank you for that work. Thank you for that work. Yes, integrated care coordinator, multi-service organization, FQHCs, overseeing the behavioral health programs. Love it. Manager primary care, PCAs. Thank you. Thank you for the work you do at PCAs. Public health at city health department. Yes, PCMH. Deb and Maya are very familiar with the PCMH space. Okay. This is incredible. So about half of the folks on, you guys are already moving and grooving in this integrated care space. So we've definitely got some gems for you today. And for the 30% of you in behavioral health and the 22% of you who are in primary care, we've got gems for you too. That's the beauty of having Maya and Deb doing this presentation. Clinical psychologist, wonderful. In integrated care professional and health department, ambulatory care office strategy person, Sarah. You are a rock star. It's so wonderful to have you on, all of you on today. Hazel, adult program specialist, elder affairs care. Look, Sarah, I see that smiley face. You were probably slammed. Let's just acknowledge we're all slammed today. So maybe we should move along to the next slide so we can get to the content and you don't have to listen to me pratter any longer than necessary. So as I mentioned, this is the second webinar in our series this year. And here's a little recap from last time. If you hung out for 90 minutes with Maya, Deb, and our colleague Amy a couple months ago, you learned about quality improvement tips for integrated care settings. And if you didn't spend that time hanging out, no worries. We actually made a tip sheet of some of the key takeaways from that session. So I think Chaim or Kimmy is going to put a link in the chat so that if you want to download this, and have it by your computer or print it and have it on hand, you can. And if you don't have time to watch that 90-minute webinar, which we know not everybody does, this is sort of an overview that'll get you up and going. And if you have more questions, you can watch the webinar. So just wanted to let you know that this is available, and we'll be making a tip sheet off of this webinar as well. Just trying to make sure that you all get the information in a way that's usable. Especially during this really hectic time in our field. Next slide. So our presenters today did not escape this activity that I asked everyone to participate in with the 3 words. So Deb, in addition to being a senior director, and I have it written down, so in addition to being our brilliant senior director, she is also a doer, a creator, and an empathetic individual. And I have to say all of those things are true. And Maya, in addition to being our senior program manager and also completely brilliant, she is a champion, nimble across this broad space that we all have to function in, and a proven expert. And I don't think there are truer words to describe her or Deb than proven experts in this space. Next slide. So with that, I'm going to turn it over to our brilliant proven experts to walk us through the key objectives and take us to the end of the presentation. As usual, at the end, we'll have our office hours, which will be time that folks, you can all ask us the specific questions that we didn't get to and hear more from Maya and Deb. And feel free to keep the conversation going in the chat. I'll be here, as will others, to respond to you as we move along. So Deb, I'm going to pass the mic to you now.
Thank you so much, Kristen. And yes, I want to reiterate, please feel free to chat, because we live for chat. It's really difficult to sort of be dynamic and interesting in this sort of virtual modality. So we'd like to keep the conversation going throughout our presentations, because it is really a conversation. I don't think Maya and I are going to tell you anything that's overtly new in your world, since most of you work either in a behavioral health or primary care and or a integrated healthcare setting. So our goals today, our objectives is to talk about screenings and more screenings. We're going to give you some ideas on what we think would be good decision-making tools and what screenings you should do or recommend for your audience and for your populations. We're going to talk about selecting preventive service care screening tools, identifying and operationalizing sustainable processes when doing that, and staff training and documentation. And then I'm going to open with a really sort of brief case study about screening tools, and more importantly, the complexities of all of it and what's on the primary care agenda when it comes to screening tools, especially thinking about the integration of healthcare services and in these settings that we have nowadays. Next slide. So I'm really big on visuals. So I grabbed a couple of screenshots of both a sort of basic AAFP recommended preventive service screening workflow grid, and then also the prepare tool. And I want you to take note that there's a lot of questions on there. And typically we see patients come into a practice setting and we're thinking in our heads that there's this rotation of service that should happen within this very specific time frame. And I think at this point, we're looking at between 45 minutes and an hour or 60 minutes of the ideal sort of rotation of services for a patient. But can you imagine all that you need to do in terms of servicing a patient? All has to happen, including all these questions. So we want to make sure we mention, with all due respect, we understand it's a lot, that we pay homage to both our behavioral health and our primary care providers, because we respectfully understand there's a lot to do and it takes a team to make this effort doable. Next slide. So here's my opening about what's happening in the primary care setting. And again, the lot is about 80 different topics of screenings and recommendations that the United States Preventive Service Task Force has identified. 80. Right, I showed you one example, but there's 80 different topics. And quite honestly, it's unreasonable to think one individual provider can then now screen for 80 different things, but certainly we've learned to take in who our communities are, what their needs are, and think about what the most appropriate screening tools that would leverage benefit for them. But I wanted to make sure you make note of that if you didn't know, now you know today. There's a lot going on in terms of screenings. And there's a lot of barriers, right, that exist to implement these evidence-based recommendations, like things that you should understand and take in for your patient population. Some of those barriers are knowledge or awareness on our providers and or our practices, like what these screenings are supposed to elicit for them. Time, obviously, because we talked about that cycle time, that rotation of service that should happen, like getting it all in 45 minutes, right? Social barriers, right? How do you communicate with someone if in fact that you don't speak the language or understand their culture, and vice versa. In addition to those issues, recommendations of behavioral health counseling are often not even implemented, right? So you've got some behavioral health screenings that are sort of put out there in the beginning, like PHQ-2s and PHQ-9s. But even though you do and conduct those screenings, what happens after that screening is done and a positive is identified, even that is not sort of worked through in a sort of in a seamless way, in an efficient way. More recently, we've sort of indoctrinated social determinants of health screening, which is what I showed you in that previous slide, that prepare tool. It's becoming way more prevalent as a mandatory screening opportunity. Health plans desire this information. Why? Because they consider that this information captures individual social welfare characteristics. They don't have those characteristics. So they want to sort of leverage the primary care setting, ideally, to be able to capture that information. And that's because life circumstances can contribute and or inhibit a patient meeting their clinical, social, emotional goals, right? Like life is difficult, this disease sort of gets in the way of you telling or recommending to a patient, maybe perhaps you should walk a bit or more, or do this a bit more. And if there's other things that are sort of social and emotional barriers, but also built environment barriers, you can imagine how that can be a problem when you're making these recommendations. And like some of those commercials that I see nowadays where someone says, oh, you should do this more. And that person who is going through some sort of mental health incident is thinking that was not helpful, right? And that's not helpful. So we need to consider all these sort of at-home conditions when we're thinking about how we service our patient population. Next slide. So I say all that to say, or ask that question to you. I want you to now think about what was your organization's criteria to decide what screenings and practices would be routinely done in your environment. And that's because oftentimes we come into a space either as new employees, or perhaps we've been doing it for like that for a long time. You adopt what's new, right? You put into place what's required as a physician, as a clinician. You are using what is evidence-based and standard of care. And then something new comes along, like do a fall screening. Who wants you to do fall screening? Well, Medicare wants you to do fall screening. Why are you doing it? Because I got 3 or 4 people who are fitting in that Medicare pool, and therefore I'm going to now conduct fall screenings. But then did you ask yourself, is this a sort of a thing that works well for my patient population, to now incorporate that into my technology, incorporate that into my workflow? Is fall screening the best thing to do? And I'm here to say, yeah, it is, especially if you have patients in that sort of category. But how do providers know if their screening tools reflect and gather information that's best suited for their patient population? So I'm asking that question as I want you to think about it. And in the next few slides, I'm going to give you my 2 cents on how you would sort of think about going through the process of doing this reflection and doing the work of sort of gathering good information, accurate information, validatable information, and then creating a compendium of appropriate screening tools that you want to enact in your practices. Next slide. So I want you to reflect on your practices community and their demographic. Some of us organically are like, oh yeah, I work in a rural environment, or I work in a suburban environment, or I work in an urban environment. And there's these assumptions that you have, but sometimes we can work in environments where your practice setting is, say in a suburban environment, but not so far away, maybe 1 or 5 miles away, you do have the rural environment. And therefore, you need to understand that while physically your space is in a condition where the access is pretty easy, right? Because there's parking and et cetera, but you also have to think about how do others get access to your facility? So you have to think about what's in my current radius, 1 to 5 miles, or what else is happening? Who else is here that offers the same type of services or offers complementary services to what we offer here in my practice, so that I can then now make sure that my patients' needs are being met. One way of thinking about your practice's community demographic is sort of pulling down the community needs assessment. A lot of counties are doing this work. A lot of the hospitals that we work with here in New York State all are responsible of sort of gathering this information. And what community needs assessments do, and are really sort of helpful tools to sort of allow you to not have to do all the research on your own, it brings together what's the health aspect of the patient population, or I shouldn't say population, of the community, right? The people who live there. What is the educational opportunities or lack thereof? What's the built environment or home environment? Where do they live? What do they live in? Are they living in public housing? Are they living in privately owned homes? Do they live on farmsteads, et cetera? What type of shopping for food is available and around them? So all these things help you understand both from where your practice sits in that community, but also what's happening outside your 4 walls. Oftentimes, we know that providers are so busy doing what they do best, they don't have the time to sort of reflect on this stuff. So we encourage that, folks who are in leadership roles, maybe administrative roles, pull some of this information together. This is my 2 cents. We think it's best that they pull some of this information together. So when you do convene your providers and stakeholders internally in your organization, they have some of that information, and that they can then now give advice or feedback based on that gathered information, instead of having them sort of do the research on their own. Next slide. So let's reflect a little bit on the social and economic conditions. So we talked a little about the community and the demographic, where they're coming from, whether they have access to, whether it be transportation or not transportation, what's the educational level, but all this stuff, including the social and economic conditions, is literally part of what you should be gathering, besides the screening tools. And sometimes the screening tools allow you to gather this information as an example. So this is some conditions and considerations when we think about age. What is the average age of your patient population? Funny enough, I work with an organization. I work with an FQHC here in New York, same project, FQHC here in New York, and I should say New York City. This is upstate New York, where it's way more rural. The average age in that FQHC of patient populations was 58. I work in FQHC upstate New York, way more rural community. The average age was 9. The average age of the patient population, they had that many young people coming through that door that it literally bent the curve and had the average age of 9. Both of them FQHCs, both of them focusing and working on the same project and objective. But can you imagine if you're thinking about screening tools to adopt? If I told both organizations, you should do the same screening tools, it's a bit silly. It's a bit sort of like, you don't have the right information, Deborah, if you're recommending I do fall screening on my average age of 9 population. Yes, you might have a patient that comes in the door in that average age of 9. However, I would not sort of invest a lot of time and effort on pulling together my entire team to create a brand new workflow to make sure fall screenings work. And I'm using fall screenings as an example. Certainly, I understand that the benefit and relevance of that, as I have parents who would definitely need a fall screening every once in a while. But that is what we want you to consider, and that's the decision making that happens. Why is age important? Why is it important for you to know what is my age of my population? It's because you want to make sure, do I have an aging population? Am I relevant? Because I have a geriatrician here in my practice and my average age is 9. Unless, of course, I brought in the geriatrician because right now my average age is 58, but my population is rapidly aging, and therefore we need to prepare those patients to be thinking about the quality of life they want to maintain since they're healthy now, and my geriatrician is going to help me secure that, right? You also want to think about conditions such as sex and sexual identity. Many organizations that we work with, unfortunately, still have this 2-category thing, right? There are more than 2 categories. You want to ensure any patient walking through your door now has the opportunity to self-identify their sexual orientation and feel confident they're going to have a response to that, but more importantly, care that is guided in the way that the staff is engaged, but also informed on how the care should be rendered from me, right? Especially say I identify as non-binary. What do you do with me if I identify as that? How do you then now identify which workflow? Is it male? Is it female? What do I need to do for that patient? That means you need to be educated so that you know how to respond to those patients' needs. The same for race and language. Is health equity on your agenda? Are you working on diversity, equity, inclusion? Are you considering and working on or identifying how does my staff communicate to our patient population? Are we doing it in a way that they feel there's class awareness, which is culturally and linguistically appropriate services? Is that rooted in how you deliver care, how you onboard patients, how you educate them where to go? The lab is to the left, the exam room is to the right. All those things go into when you pull in some of the social and economic conditions, especially if you're thinking about patient and their trust and recommendations that come from you. You need to also consider those things as well. We're also considering income. Is it low? Is it medium? Is it high? You might physically sit in an area where it's low income because maybe that's where it was easy enough to find a space to grow your practice, but also know that you have other income streams coming into your practice, and therefore you need to respond to that. And then finally, but not finally, it's built environment. Are there buildings, the parks, transportation, healthy food access, as I mentioned before, walkability and bikeability. I didn't know how to spell bikeability, but yes, all those things are really important. Next slide. And then you take those reflections and then you think about your products and services. So one, you need to sort of go outside and go, what's happening outside? What's the community look like? What's the social and economic condition? What's the circumstance in which they're coming in? Then you think about, well, what are the products and services that we offer? Does it actually align with what we should be offering to our community of practice? And so sometimes it is best that you look back and say, oh, I didn't know we offered substance use and alcohol use disorder, as I mentioned. And that's important. I worked with another practice. I was doing a customer service training, and they are what New York State is considered an Article 28. This definition is basically a practice that is now paid because there's a lot of low insured or no insured patients that hit their doors. In New York State creates an agreement with these practices. So they have this designation of Article 28. They onboarded some new staff members. This young lady was sitting at the front desk and was like, oh, so annoyed and frustrated that all these patients were coming in there. And she was like, I think they're like drug users. And I said, do you know that your practice offers substance use disorder treatment and alcohol use disorder treatment? And she was like, no. And she said it so like, ugh. I was in shock. But on their onboarding of their new staff, they felt that if you say things like that, you're going to now get people to not want to work there. Major miscommunication, major misunderstanding. She, in fact, was very biased against patients that were coming through their door that looked like or appeared to her as if they had some drug problems and or alcohol problems. And she was the first person that they met. She was the hello. She was the front desk. She was the one that handed them a chart and some papers to fill out. And can you imagine how that must have turned off several people? And just because someone might be addicted to drugs doesn't mean that they're not aware when they're being discriminated against. So I say that to say, you really need to make sure from the beginning to the end, when you have staff, when you have new members coming on board, if you don't already, make sure that there's a complete and total understanding of the products and services you offer. More importantly, making sure that your patient population knows, oh, I didn't know I can get access to behavioral health care in this facility. I didn't know that. There's no signs. I didn't know that they know that they can access those products and services. Again, really important stuff. Next slide. So what is the benefits of analyzing all this stuff that I'm talking about? Why do you want to look at all this stuff? Look at both the external and the internal. Well, it really does help you shape your line of service, right? What you did perhaps 20 years ago in healthcare, you might have blown down the doors. We're doing integrated care. We're doing integrated care good, right? Integrated care didn't exist like that 20 years ago outside of, say, academic settings. And not really good, right? It wasn't this sort of complement of care that's done between health professionals. Now we see that everyone's talking to each other. We're using technology to allow us to have that seamless care plan, that unified care plan of supporting patients, getting to their goal and asking the patients, and let's talk about integration, we're asking the patients, what are your goals? That really wasn't something that we heard about in healthcare. And now it literally is part of the narrative. It is not only about the individual primary care provider sort of rendering support and making recommendations, it's who else needs to now be in this conversation, and that includes the patient. But the analysis of all this information helps you shape a service line. It helps you validate the investment in staff. Oftentimes we hear practices that don't consider themselves large enough and or in need enough and say things like, well, I can't afford a licensed clinical social worker. I can't afford a behavioral health provider. And we wince a bit, right? Because when we hear that, we're assuming that you haven't done the work of knowing and understanding that it's okay not to be okay. And your patients may not say they're not okay because perhaps you are biasing the conversation because you don't have any support to help them. If they do that PHQ-2, you automatically send them out the door. If they do that PHQ-9, that anxiety test, the DAS tool, whatever it is, when you do those screening tools, You send them out the door. And for them now, they have to repeat that story. They know you, right? They've been being able to sort of engage with you. You've been their PCP for years, but now they got to walk out the door and tell someone else their story. Can you imagine the discomfort of having to sort of disclose information to yet another stranger? It's so ideal that when we think about embedding some of this additional staff, that you not only see the financial benefit, but also, will that help my patient population? If the demand is there, you want to think about that investment and how you can sort of yield that benefit for your patients. It also helps to inform your screening tools and protocols. Like I just mentioned, when you do the work, you know for sure whether or not that full screening tool is a tool that I should be now making sure that I do on every patient walking through the door, instead of maybe there's something else that I should incorporate in my day-to-day. So I'm just, again, using that as an example, but the analysis of that information helps you understand the culture of your population. It helps you understand that the considerations that you need to make in order to make sure that down the line, you can project. If you have an average age of 58, those patients are going to age. And you can then now say to yourself, maybe I do need a geriatrician to start now so that we can continue this sort of journey of making sure our patients age in a healthy way, in a well way, right? Next slide. So where do you get all this information from besides the screening tools? Well, we have lots of resources for data. Yay. We have the EHR. I know we hate to use it, but it's not only meant for you to document the encounter, right? It's not only meant for you to say or memorialize the presentation of the patient and what your recommendations were and then what you did in terms of treatment. It's also a data diving pool of great information, right? You also have patient intake forms. Most of that information is now translated and dumped into the EHR. It allows you to look at things such as, wow, I'm looking at perhaps how well I'm doing at my mammography screening rate, right? And then you say, oh, I'm going to dig in a little bit. How am I doing amongst my BIPOC community when it comes to mammography screening? And you're like, oh, my goodness, not so good. I never knew that because my overall screening rate is 65%. That's way above the national average. I'm great. But then when you dig in a little bit more, you see, I do have some disparity in the services, right? I do have some disparity in the outcomes. So that's why it's important that you go to these resources and sort of dig in and analyze a little bit. Screening tools are also a great reference or resource for data. Again, data means it's sort of plotted in this example. So your social determinants of health screenings like your Prepare tool, your other screenings like your sexual orientation and gender identity screening tools also help you understand what else is happening in that sexual orientation category. You can also do some retrospective coding and billing reporting and or data analysis. This allows you to go back and say, oh, I thought I had a lot of patients who were diabetes and perhaps also had a co-condition like diabetes and schizophrenia, when in fact I have way fewer diabetic schizophrenics. They just visit me a lot, right? So that retrospective review on coding and billing is really helpful. And then finally, as I had already mentioned, but it's not an exhaustive list that I'm putting here, it is that community needs assessment. You can't do all the research on your own. So it's definitely a great tool to sort of get a 30,000-foot view of what is our county or what is our state saying as the need of our communities that we are in. Next slide. Then you gather this information, done some analysis, you data dived into your tools, and then you implement and you roll out your screening tools. Maia's going to sort of talk about the sort of day-to-day of this, but again, I'm trying to give you sort of like a, it would be a benefit if you sort of saw these things in this lens where there is work that needs to get done to sort of roll out a good screening and interventional program. When you implement these tools, you're doing it based on evidence. You're doing it based on obviously decisions that give the decisions that were from leveraged information, right? Good validatable information. You're going to roll out evidence-based screening tools. You're going to use internal and external data to help you determine those best screening tools. you're always going to rethink what would serve my population best. There's a whole lot of organizations with measuring sticks, right? And they're like all pushing information back to you, but you should use that information, but you should also understand, what is my population? What are my patients saying, right? So some of that might be coming from feedback from visits, right? Like the patient experience surveys. They're also sort of mentioning what their needs are. The tools that you might select are obviously sort of like the game changers when we think about the entryway of sort of behavioral health, which is way more that are out there. But right now, we are seeing a lot of PHQ-2 adoption, and pretty much every EHR has that capability if it's certified. So the EHR being certified by CCHIT, which is Certification Commission of Health Information Technology. So if you're using one of these tools or products that's able to report back out to MIPS and to UDS and to all the other reporting mechanisms, you got PHQ-2, PHQ-9, you've got the GAD tool and the audit tool, and there's several others, but these are sort of really good structured tools that does help you gather information. Then you develop a plan and inform all your stakeholders. Who are your stakeholders? Someone decided we're going to roll out doing PHQ-9s. Who are your stakeholders? Your team, your patients, the community, right? You want to make sure that they're informed. You want to make sure, first of all, that when you start to conduct these things, that you have a mechanism to get these patients to the right care as per referral or as per needed, when you think about the internal opportunity of having the handoff within your practice setting. So you want to think about your workflows. You want to think about your policies. My goodness, you want to think about, how do you write a procedure that's now specific to those who are actually doing the work, and not writing a procedure that you need a PhD to figure out, well, what am I supposed to do as a medical assistant in this sort of thing, right? It should be literally written so that it's understandable and doable at the end of the day, right? Next slide. And now fast forward 1 year, we're going to do it again, right? We're going to do it again. We're going to go back a year later and say to ourselves, let's look back at the community. Let's look back at our technology. Let's look back at our patient intake forms. We're going to look back at our screening tools. We're going to do some data diving on retrospective coding and billing. And we're going to now, if there's a new one, pull in that community needs assessment. Why? Because it allows you to refocus. And sometimes you need to sort of say, yeah, we thought this was going to be a good thing, but it doesn't. Let's now modify and change our direction, because that is okay to do. You can have all the well intentions in the world, but if you don't fix them by calling the question at some interval of time, a year and a half, something has to now, be said, because what you're doing is not sort of helping. It's sort of making everybody crazy. And then you're making all these referrals and you're not getting any responses back and in the community. So why are we doing it that way and continually doing it that way? So it's okay to come back and say, let's do our due diligence. Let's rework this work and making sure we're on target, and let's redeploy, right? And sometimes it's not a lot of work, but it's reassessing what you've got going on. And it's sort of like a two-step in my head. Next slide. So as I sort of hinted to, screenings need to be linked to support, right? So you may not be like in that slide I showed with primary care, community health center that has all of those service lines, right? You may not be one of those. You might have just a couple of provider specialists and some behavioral health access that's limited. And now what do you do? So you're offering all these screenings, and I want to make sure that we go through this reality checklist, so that the misunderstanding of just because you screen doesn't mean that those patients or you as a physician have access to support those patients upon that diagnosis, right? So screening for behavioral health conditions doesn't automatically mean that you have a mechanism to get those patients into the right care. So before you roll that out, you need to think about what I have going on. Who do we have access to if we don't have the behavioral health services internally? And how do we escalate a referral to get patients into the care that they need? Because we've done the screening. We know that there's a problem. That patient has mentioned more than once they have suicidal tendencies. We need to make sure that we get access to care. So doing that as part of your due diligence is also part of your reckoning of this work. Screenings, as I've had to say more than once to my provider community, doesn't mean that you could increase the billable service. Sometimes it's just the information being gathered allows you to treat better. It doesn't mean that you automatically are able to code higher or more detailed for that encounter. So don't make that assumption. Some of the health plans are like, listen, mandatorily, you need to do this, this, and this. And I might throw you a few dollars for doing those things, but don't make that assumption that a screening, right, for a lot of stuff equals a higher billable service. Screening a patient and education doesn't equal adherence, right? Just because you told me, Deborah, you are obese and you need to work on that, doesn't mean that I'm like, got it. I'll come back in a year and I will not be obese. It doesn't work that way, right? So there needs to be this constant sort of redesign of what's the expectation from your provider's side, what are the goals that that patient should seek, and then more importantly, did they agree with those goals that you thought would be a really good idea? Even if that's a smoking reduction goal or something like that, where it requires the patient to actually do 99% of the work. Your 1% is sort of giving them the sort of the mindset and thinking like, hey, you know, the best idea is to now not be obese, not smoke a lot, not chew on that tobacco, but instead to now adopt maybe more healthier habits. So let's do some reduction in that particular activity. And then finally on our checklist is finding referral support may require your primary care network to network with behavioral health providers and develop referral compacts. So if you can't integrate, if you can't push those providers into your practice where there's a seamless EHR and the handoff is super cool, then you want to create those community compacts. Those community compacts allows you to make sure that you and that external provider are on the same page. This is what you expect. I'm going to send you my patient. This is Deborah. She's very sensitive, but she's a doer. You give it in your head and she's going to be willing to do it. How are they going to respond to you so that you now have information on what's happening as Deborah progresses in that environment? Next slide. Oh, I talked so much. I talked up into Maia's slides. So
You've never, Deb, you've never talked too much, I promise. All right, so my name is Maia, and I'm going to take over from here and really talk about the nuts and the bolts of making this happen in a real practice setting, ideally an integrated setting, but really any practice setting. When you have to implement a new screening, how do you do it? Where do you begin? Well, that's hopefully at the end of this session, we'll have answered some of those questions for ourselves. Next slide. So I created a roadmap to start us out. And some of this covers what it really does pick up where Deb left us off. Because first and foremost, we really need to understand our patient population. And of course, Deb sort of presented it looking at a wider level patient population within your community, within your region, and this is really important. You also need to do this within your practice itself. Look at some of your patient demographics, look at social determinant of health data if you are collecting it, and any special populations that you may know of that exist. Like maybe some of you are seeing a lot of patients who were refugees. You know, they have specific needs that you could really consider addressing within your screenings. Once you sort of understand your population, it's time to set priorities and select your screening tools. And Deb definitely kicked us off with selecting some of those screening tools. I think other things to think about when we're actually selecting the tools is thinking about some of the other priorities you may have that are related to the screening itself. For example, there's been a lot of emphasis on avoiding utilization of costs, not sending patients to unnecessary tests, trying to avoid the hospital. You know, some of these things have are sort of like ancillary related to screenings. So it is important to keep in mind. And once we sort of select which tool we want to use, and I would say it's great to sort of vet these tools, try them out, implement an old school PDSA cycle and try it out with, just one care team and see whether they like it. We'll get into the nuts and bolts of this. Also see what's integrated with your EHR, because if it's not integrated in your EHR, then you may want to sort of rethink it and find a tool that's a little bit more integrated and easy to work from in a reporting standpoint. So third, we have to define our care team roles and responsibilities. And this is definitely related to the specific screening itself. And what I want you to think about is who is actually conducting the tools, and then what happens when there's a positive screen? What kind of handoff occurs? What are the next steps for the care team that's working with this patient? What are the next steps for the patient themselves? And how can we make that process as smooth as possible? Finally, we need to operationalize the screening tool. We need to put it into place, set it into action, make sure we're creating some really good workflows that aren't just sort of, policy mumbo jumbo. We want them to be something that can be used for ongoing training, something that you could even hang in a nursing station, that look very clear, that use basic language, because we like really hands-on workflows for this. And then finally, there needs to be a plan for ongoing education, training, and cross-training. This is unfortunately something that is an ever-evolving landscape. And so we need to make sure we have a plan to retrain not just new staff, but existing staff on completing those tools, even reviewing the data together and modifying how it's being performed. All right, next slide. So before we even initiate work related to a screening, we often like to look at establishing buy-in among staff. It's really, really important to communicate why we're doing something before telling a group of people that they have to do it. And I would say, in some cases, you may be told that you have to perform a screening by an external agency. And to be honest, that's okay. It's totally fine to be told by an external entity that you have to start doing a screening. Just be honest and transparent about that with your staff so that they know that's part of the why as well. And there may be a whole wide variety of reasons why we're doing this beyond just that. For example, most likely it's going to improve the care for your patients. It will, allow for early intervention. There's a lot of good things in addition to being told you have to do certain screenings. We, of course, want to include any discussion of population-specific factors. We're a big fan of stratifying data, making sure that different populations are getting all of their needs addressed. And of course, we like to think about discussing plans for sharing of data once the screening is initiated. It's really important to start thinking about that at the beginning of the process, rather than waiting until it's implemented and then thinking, oh God, what do we do with the data? How are we going to process this and make sure that we're doing something useful with it? And of course, addressing any care gaps. Next slide. So then we need to define our care team. And you can see that this is a pretty big list. What we tried to do here is identify all the possible team members on your primary care core team, and also some members that might be on an extended care team. And I think for you, what I want you to take away from this is that your organizations are going to have your own unique makeup of who falls on your care team, particularly in an integrated care environment. So don't feel like you need to maintain the buckets that I've presented here today. There's going to be a lot of crossover. Rejigger it. Maybe your care managers are on your extended care team and your behavioral health specialists are on your core team. That's fine. It's more that we all need to think about what the varying pieces in this screening puzzle, right? We all have a role and we all need to be sort of cross-trained to do the screenings to make sure that they're happening and that it's not dependent on, your medical assistant being there today in order to get that screening done for the patient. Next slide. So how do we do this? I hope you can see this example. This is actually a real world example. It's a little bit old now. We worked with a group on a patient-centered medical home recognition project where we realized that there were a whole wide variety of tasks being put in front of our care team members. And we wanted to make sure that there was real clarity around what needed to be done and who was performing it. And so this was just a really snazzy tool that honestly, if any of you have anything better, please send it to me, because we still haven't found one that sort of checked all the boxes like this. You definitely want to have information about delineating roles and responsibilities on your job descriptions. But a tool like this that can be reviewed regularly with staff, it can be updated really easily, it can be posted at a nursing station, it really helps to solidify roles and responsibilities in the real time to make sure that everybody's doing what they're tasked with doing in a very clear way. So next slide. In this particular organization, the medical assistant was tasked with performing the PHQ-2 tool. So that was the initial line of screening for depression screening. What this doesn't say, and it is always important to look at these sort of things with a critical eye. This was probably 5 years ago. Now I would like a little bit more information about if the patient screens positive on that PHQ-2, who's doing the PHQ-9? Is it also the medical assistant? Because this seems to imply that it's not. And then, of course, if you have a patient screen positive on a PHQ-9, what is the plan? What's the action that's going to be taken? Most likely, it's not going to be that LPN that's taking it to the next step. So who is it and how do we know? Next slide. So once we sort of figure out what tool we're doing and who's going to do it, I want you to look and see what sort of resources do you have available to you. And I do want you to look at your available technology. It is your friend, it is your assistant. And so there's a few different trends in screening that I did want to highlight. So first and foremost, clinical decision support has been around for a while. For those of you not familiar with CDSS alerts, it is those annoying pop-ups that many of you, if you're clinicians, you may click out of as soon as you enter into a patient chart. So these actually do serve a purpose. They're pop-up reminders saying, hey, you're opening up this patient's chart, and I just want you to know that this patient is due for their annual depression screening, or this patient is due to be screened for breast cancer screening. So while you're with the patient, this is just a point of care reminder to get you to make that necessary referral or do the screening. And oftentimes they are actually really smart. So when you have the pop-up, you can actually click right into the tool, which I think is really cool. And it sort of reduces the extra barrier of finding the right form and, dropping it into your note. It's right there. It's ready to go. Another thing that is absolutely critical for screenings is registries. And this is where we'll spend a little bit of time because there is great variation in the registries that are available. We have manual registries. That's just when you have somebody on your team that's running lists. They often end up in an Excel file. And then you have somebody manually performing outreach. That might be a call, it might be a letter, it might be a message through the patient portal. We have also had the privilege of working with some groups, usually larger healthcare systems that have access to very sophisticated population management programs. And these are really cool. You can do either outreach campaigns around a specific type of screening or a vaccination like the flu vaccine. They also sometimes have programs where you can essentially pull up the daily schedule for any given care team or provider, and it will automatically identify for you some of the gaps for that patient. This patient's due for depression screening. This patient is due for a colonoscopy. So it's really neat, and it's often used when it's available during the daily huddle, that the care team gathers together, they review this action list, so to speak, and identify which patients need screening so that the process can be started even before the patient arrives in the practice. So I just want to take a second. If any of you actually have some of these more sophisticated population management programs, can you type it into the chat and let us know if you do, and what the software is actually called, or what the program is called, because I would love to see whether or not those are being used. Okay, so we have a next gen population health. Great. I actually do think I've seen that one. Anybody else? IBM Watson Vital. Yes, so I definitely am familiar with that. Actually, the previous group whose workflow I just showed, they were using that program, and it is really neat. Anybody else? Okay, so there are definitely varying levels of groups that are using this type of population management health. I don't want you to feel like, you know, these are resources that are completely unreachable. I actually do think that they will become more accessible to more groups. You know, at this point, okay, so actually we have a few additional ones I just want to point out: ECW population health and evolve workflows. Okay, that's interesting. So you can do certain screenings at intake and then periodically thereafter. How cool. I mean, that is when technology really is working for you, that it sort of integrates with your screening and allows for seamless population health management. Okay, next slide. So here are a few examples. I wanted to highlight CDSS alerts just for those of you that are less familiar. This is a good example of one that really was integrated. So the pop-up came up, the patient was due for expert screening, and the clinician, whoever it was on the care team, could click in and just complete that screening in real time. It is a super snazzy tool to have because they got that done with you know, a lot of very few clicks, I should say, ease of workflow, and then they don't have to do it again until they actually establish the alert to come up again. So the cool thing about CDSS alerts is you decide, you can set on the back end how often patients should be screened. And if you want to do it a little bit more frequently than say is generally recommended, that's fine. You can have it pop up more frequently. All right, next slide. And so then I wanted to talk a little bit more about registries. So I already discussed that we have manual reports that can be run by individuals. These often end up in Excel files. They have to be, you know, manually worked on. The outreach is manual, but they're very effective and they're not going anywhere fast. You know, I think this is sort of the original type of registry. I would say it is dependent on one thing in particular. We have to make sure our screening data all ends up in an electronic fashion. So it has to be within a searchable field in order for us to even get this report. Anything that's free texted, we're not going to be able to run a report like this. And honestly, I think the majority of groups I work with are still using manual registries. There really isn't anything wrong with them. We just have to make sure in those cases, we have a really good workflow established to make sure that it's actually happening. It's being done on a regular basis that we decide, and that we have the resources to actually perform that outreach. The second version is when we have a built-in electronic registry within our EHR that may be run manually, but it's sort of pre-built. That's really the next level. I think most of the time in that case that the outreach is still manual, even if the registry itself is sort of something that happens on the back end without any person hitting a button to make it happen. The third version is an automated registry. So these are reports that are built into the system that automatically run on a selected frequency. This is pretty cool. And actually most EMRs have the ability to do this. You just have to set it up. But this is sort of like one step behind a fully integrated population management platform. I'm definitely seeing the use of automated registries more often. The glitch is that, you know, sometimes they do initiate outreach via a patient portal or even sometimes text messages. So using electronic platforms that are available through the EHR. Nonetheless, those aren't foolproof, and particularly for a more of a community population that may not always be updating the most up-to-date cell phone number. It's not always, and you know, and certainly portals have mixed reviews, not how everybody is accessing the portal. So there, you know, nothing is quite perfect yet, but that's why we make sure we have a multi-layered approach, right? We have a registry so we can do proactive outreach, and we have CDSS alerts. So when that patient walks in and has a walk-in appointment is right in front of you, you can actually get those screenings done in real time. Finally, we have an integrated real-time population management platform. This is very cool. I have a fun example to show you. And I do hope that this is sort of the direction we will all end up in some way, somehow. But certainly the need for it, the use of it is becoming more readily available to everybody. Next slide. So this is an example. Many of you may be familiar with this. This is a very basic registry. It was created, this one's for breast cancer screening. It was created just by running a report of all patients in the eligible population that were due for breast cancer screening. And then the staff member assigned can take this, they can perform all the outreach, they can make the referrals, get patients into the office. Honestly, as I said, this is very effective. Next slide. And this is our fancy example. This is a pretty cool dashboard. In this particular case, the view you're looking at here, a campaign was run to notify patients who are due for a flu vaccine. And what's sort of neat about this, of course, is all these graphs. You know, right from looking at this, you know the number of patients in your population, you know the percent that is male, female, it's broken down by age. It's pretty neat, right? And so this same sort of platform is what practices may be able to use to look at their daily schedules and see any gaps in care and initiate screenings for patients. So this is just some examples, and I know many of you have some examples as well that you're using. Next slide. Okay, and so when we have an interactive registry, it's also really important to have workflows, right? It doesn't run itself. And in some cases, there's even, actually in most cases, there's even more training required to make sure that staff are using it and they're using it correctly. And you know what we find with this is often there's a lot of training when a software like that, a population management dashboard, is rolled out initially, but there may not be enough retraining. And like any good software, there often are a lot of updates. And so Deb and I did a project a few years ago with a group that had implemented a population management software, and it really had so much possibilities, but we found that the staff really, you know, sort of got frustrated because new staff members would come in, they didn't feel like they were fully trained and they weren't really utilizing it to the extent that they could. And then the IT department would send out email updates, but of course, you know, nobody reads email. So, so they wanted more live trainings. And so that was, you know, really great feedback. And we were able to jump in, and during a staff retreat, they did a live training, and there was such good outcomes from that. There was great, the staff appreciated it, and ultimately the patients did as well, because we could tell right off the bat, there was so much more use of that tool. Next slide. So once we establish what tools we're using, who's doing this screening, and what sort of resources we have available to actually get it done, we need to write it down. And so, you know, we're big on writing everything down in policies and procedures, but we want to make sure when you're doing this, you're writing it for the people. Don't just use sort of the high level policy language. Let's really create policies and documentation that we can use to train our staff. And we like to, staff training really should be related to any activity that informs the practice, organization, and policy. We want to take what people are doing and turn it into the documentation rather than vice versa. Sometimes we're making big decisions within a policy, but most of the time we're really trying to figure out our standard practice. And I do suggest, if you're really rolling out a brand new tool, start doing it on a small scale. Do a PDSA cycle and figure out, you know, how does this work? What are some, tweak it a little, you know, maybe figure out some of the nuances of how the handoff is going for patients that screen positive, or the referral sources. You know, you sort of want to figure out what's going on with these screenings before you actually write your documentation and policy. And then we do want to make sure that when you're writing your set of guidelines, that you're outlining the plan to address certain issues. This is key. And actually, I would take a moment here to say that We're seeing much more of this. We do a lot of work with patient-centered medical home, and NCQA is now insisting that all of our policies identify what happens when a patient screens positive. What is the action that we are going to take to ensure that it's clearly delineated in the documentation? We also use policies to communicate our values, our philosophy, our culture. This is the documentation that's the sort of the foundation of your organization. So make sure it reflects that rather than something that's just on the side and collecting dust. Next slide. So procedures should tell you how to conduct the policy. So we want to understand why we need procedures. We must look at what we need to be in control. And so really you're trying to identify the areas of variability in your practice, like how do staff room the patients, right? And what are some of the differences there based on your provider care teams or your departments? How are patients informed about same-day appointments or screenings? You know, looking into some of the communication lines with your patients is really important because we want to make sure that no matter when a patient makes that appointment, they still can get all the screenings and all the care as if they scheduled it in advance. And we want to know how the care team is organized to conduct expert screenings. This is one where we definitely need to have the full plan in place, not just how to do the screening, but what happens next. Next slide. So this is an example of an actual policy that I worked on with some staff. And so what we were trying to do is rather than having a separate policy for each different screening that was occurring in the practice, we wanted to have one policy that really looked at all the different preventive screenings that were occurring. And so what we tried to do is clearly identify which standardized tools could be used to complete the screenings. So as you can see there is a lot of mention of tools. And under the childhood development screening, you'll see that there are different tools for different age groups. Mention them all. Don't leave any out. This is your source. This is your guide for patients. We need to ensure that the tools are integrated into the EHR. I already mentioned that. Can't mention that enough. And I would say when we were developing this policy together, there was a few tools that were still really honestly aspirational. You know, we had them on paper, but it wasn't a sustainable process to really, you know, continually scan them in. So we started to think about what process we needed to do to implement them in the EMR itself. And finally, of course, we do need to clarify who is conducting these screenings. Next slide. So now it's your turn. This is your first quiz. So I'm going to read this little piece of documentation, and then I want you to let me know what's great about this policy documentation and what could be improved. So this is for depression screening. Depression screening will be conducted using the PHQ-2 and PHQ-9 screening tools. All patients 18 years and older will receive the PHQ screening annually. PHQ-9 screenings will be conducted for patients who receive a positive PHQ-2 screening. Staff should complete the PHQ-2 screen when an alert for the PHQ-9 is visible in a patient record. All right, what do you think? What's great about this policy and where do you think it could be improved? So I will wait to see what comes into the chat. And you get an extra gold star for right answers. No, there are no right answers, don't worry. Okay, so the steps are clear, I agree. So the passive, so the passive voice eludes the subject conducting the screening. Ah, good one. What happens if a patient screens positive? That is absolutely the big one that is missing. And it stood out to me like with a sore thumb. Who completes it? Yes, you know, it's true. I felt like that could have been a lot more clear. Okay, so we have two huge gaps. Who's doing this and what happens for a positive screen? So let's take a look at the next slide. It is pretty readable. I agree with that. I mean, it's very clear. We don't want a lot of extra language in policies. It just sort of jumbles it up. So further down in the policy, they tried to address what happens if a patient screens positive. And I should clarify, this was a sort of like a blanket statement for all the screenings. So for any positive screen, the clinician will assess patient to determine if diagnostic criteria are met and identify if treatment or referral to treatment is needed. So I want to know, how could this action be improved? And how would it look different in an integrated care environment? So what should they have written instead? And you can use the PHQ-2 depression screening example, or depression screening in general. Use that as your example. What would be a great action to actually write out in a policy that we could then use to train staff? I'm sure many of you are frowning that you didn't expect to have to write a policy today, but we appreciate your efforts. Okay, so include the diagnostic criteria. Yep, that would be a great start. And be as specific as you can. What if the patient requests further help, even if the criteria were not met? Yeah, that's a great point. I think looking at some of those alternative scenarios is really helpful. And that's why often before we're writing the policy, we really need to do that workflow, right? We need to map it all out and figure out the various scenarios so we have a way of training staff to communicate that. What's considered a positive screen? Great question. That isn't even clarified. Care coordination with support systems communicated as options for patient. Yeah. So if you have care coordinators, make sure that they're available as support systems. I like that very much. What else? And and particularly those of you in an integrated care environment, what is your process for this? It isn't always possible to have a warm handoff right away, but in an ideal world, it would work. So let's see. Positive screenings are calculated by the electronic record and are brought to the attention of the clinician. The clinician decides on the follow-up plan. Okay, yeah. So that probably is, what's happening most of the time. That was probably why there was such vagueness. Perhaps identify the referral to and where based on the specific screening severity and timeline. Yes, love that. That is great language. Yep. And the last question prompts the MA to ask integrated behavioral health counselor to join the visit. Love that. Yes. When available, we need to be bringing in our team. That moment, why wait? I love that. I think that's definitely where I'm hoping to see a lot more of that. And even this group, I can tell you they had integrated behavioral health. So why wasn't there more of a mention of it? And I think it's important to make sure we're really not just in this moment considering the actual primary care team, but making sure we're really sort of moving towards integration in policies and all of our documentation. And then depending on severity, we designed an action plan for the patient. Yes, exactly. You are sort of making my PCMH work happy, sort of moving to that action plan, creating a care plan for patients. Identify what info to give the patients if further referral is being considered so that the patient is clear on the next steps. Yes, I love this. Oh my goodness. I'm going to save this chat and I'm going to save it as reference for all my future screening policies. I love this.
And Kelly mentioned about the safety, and I'm imagining, Kelly, that's for the patient and for your safety as the provider, right? You're in that space with someone feeling not so well, and you want to make sure that safety is something you can assess for. I love that.
Okay, next slide. In the interest of time, I know Chaim wants to leave time for training. The last piece of this, we've written everything down. We really need to make sure we're training our team. And it needs to be continuous. We need to have that plan for sustainability. And I really like to make sure we're checking in on these screenings at least every year. It probably should be more frequent, but I know realistically in a care environment, that's not always possible. So think of alternatives. Think of other methods of communicating to your staff, and maybe it's alternative means, use of brief video recordings, making sure that you have training and information going out in many different platforms for it. So I think this is really the key piece. We see so much emphasis on the initial training and then not enough retraining. So making sure we have a plan for sustainability long-term is critical at the onset of initiating a training. All right, next slide. So as we're coming to the end of our presentation, we just want to do a quick poll. So if you could answer, after attending this webinar, which we are at the end, can you rate your skills and comfort with selecting and utilizing screening tools and approaches to adopting screening protocols?
And I'll add, we're doing this in case more folks need to drop off, but stick around afterwards because that's when we're going to ask Deb and Maia some of the questions that folks have had in the chat. And if you have any other questions that you haven't sent in, that'll be your time to see if Deb and Maia want to play some chat Jeopardy, as it were. I only have gold stars. I can't actually give money. It doesn't appear that there's an emoji that actually translates to cold hard cash. Thank you, Wendy, for appreciating my we work in this integrated health space humor. Well, thank you everyone who answered the poll. Do you want to go ahead and go to the next slide? So I like this slide. You've got questions, we might have answers. So we've got some questions that have come in, and I can ask those real quick. And then Chaim, if you could quickly navigate a couple more slides, I think we have a little bit of info in case folks need to hop off. Yeah, so this is me. If you want to talk about integration and be an integration nerd, that's my email address. I can also make sure that you can get to someone who knows about this screening stuff, i.e. Deb and Maia directly. And then if you're curious about what we've done in our past years, you can check us out at pcdc.org/sleep and pcdc.org/diabetes. And we also have a nifty short link for this year, which is, I'll put it in the chat, pcdc.org/integration-works. And that's where you can download the tip sheet, our stuff from last time, the recording, the PowerPoint, and that's where you will get an email with today's slides in it. And also the recording and slides will be posted on this link in not too long. So go ahead and go back to that coffee hours slide. So the first question I think we had come in was from Leah, and she was wondering that they're currently working off of grant funds to implement screenings, and was curious around maybe some suggestions or information you might have around that. And I think that kind of dovetails a little bit with some other questions we've had come in the chat around who's going to do these screenings. And I think sometimes what's behind those questions is you can bill for some people doing these screenings. You can't bill for others. Grant funds might cover someone doing screenings for 2 years, but when those grant funds go away, how do you maneuver that? I don't know, Deb or Maia, if you have any guidance for folks still on around that.
I'll go first. So we see that often. No matter what the screening is, you get a grant fund and now you're rolling out, cervical cancer screening, right, on everybody, right? And some people don't even have a cervix. You're like, come on, I'll do a screening on you. And that's because you want to make sure you sort of get it right, right? The goal when you are looking at grant funded is to now see what the ROI is in sort of incorporating that opportunity and or looking for extension in your grant funding if you know flat out this is not something that you can monetize at the end of the grant. So sometimes grants are saying, we're going to fund you to create your infrastructure, get it right, be honest with yourself on what you can do and your capacity in which you can do these screenings. And then once you've got your niche together within that grant funding product or the opportunity, then think about how much further, how can I scale this if it's scalable? Or do you need other resources like bringing in staff? Sometimes the grants actually pay for the staff. We had programs here in New York where they allowed you to bring in a free LCSW in training, not what they didn't have the L yet. They were in training. The program ended. The people who were there served a great purpose, but when the program ended, the organizations didn't have any recourse. They didn't have anything in place to now support this. So before you go and say yay to a grant, ideally you're thinking about what is the goal for this? What's the long-term objective? What's the sustainability plan behind this? And then make those considerations, but you got to document time and effort and then associate that to the financial impact of having that money given to you up front. And then how do you now support that internally and finding the funds to be able to keep going with that particular screening program. I'm going to stop now.
I mean, the only thing I would add to that is, and I truly emphasize with all of you and your organizations, I mean, I feel like no time in the time I've been working in primary care have I ever seen such strain on the workforce. And, you know, so I think for me, that really speaks to two things. First, there has to be a lot of cross training. You need to make sure that this isn't reliant upon one person or one role to complete the screenings. Everybody needs to know how to do these screenings because otherwise they're just not going to happen consistently. And then the second piece is we really need to prioritize. You're not necessarily, you know, in an environment like this moment, we're not going to be able to do everything all the time. But we need to be able to set priorities and make sure that nothing completely drops off forever, right? So put it on a quality improvement agenda. You know, if you really can't perform a screening right now, then make sure it's on an agenda for 2 months from now so that you pull it back up and you really try and implement it again or make sure it's happening. And then the other piece is there isn't always incentive around to do it. There isn't always grants around, and we're definitely feeling that. But I actually think some of the justification for your screening will increasingly come from some of your quality incentive programs that you may be participating in or moving towards participating in more. You know, a lot of insurance contracts are incorporating quality. And it's, you know, whether we want to or not, this is really where the future lies. So having some of those additional care coordinators who actually can perform these trainings is going to become more common for everybody here.
Mm-hmm. That makes so much sense. And I think another question we got that's somewhat related to this, and maybe there's not a simple answer to this, but you know, Deb or Maia, do you have any resources or ideas of where folks could go that would actually tell them like how to bill for screening services if someone just wants to like look at something or have something on hand?
I wish I did. That's a ticket. You know, I think so. There's so much variation here, right? I mean, not just even by state, just figuring state variation would be one thing, but even a single insurance company that you're working with is going to have a slightly different way of submitting those codes, that information. And so, you know, it is definitely a piece of work to make sure it's all being done consistently the way that insurance company wants. But the benefit is huge. In many cases, there is a lot of money on the table for those people that really invest in this. So, and it would more than justify the staff to perform these screenings. So maybe a follow-up webinar will have to be a little bit more on incentives and value-based payment in an integrated care environment.
Noted. Yeah.
It's not a transactional activity for the most part. You're not getting get paid because you did a depression screening. You're not going to get paid because you did a DAS screening. It doesn't work that way. It's instead giving the provider more information so that they can then now come up with a plan of care that's more informed. And more importantly, it helps the insurance companies understand, oh, this is the acuity in which this patient population is running under, because they make assumptions based on how those patients come into their periphery, which is here's a demographic. And then you're gathering even more detailed information for them to better align with their budget and how they fund services and opportunities so those patients get access to the care that they need. But it's not typically a transactional, you know, for every depression screening, you get $5. However, to incentivize a depression screening, you might see a health plan throw a little money at you because your rate is on par, right? 60% are depression screen, 80% are depression screen. So that's how you can make it an opportunity. But really at the visit level, it's not like you get money for every time you do a screening.
Right. So I'm gonna go ahead and I'll try to tackle Betsy's question, Betsy, from earlier around ACEs. I just pasted in the chat the resources that I like to say, you know, everyone who's on these is an expert. So I think I said we had 176 experts in the room that's where we were at that point in time. Everyone, all of you, you're part of this field. So these are sort of the resources, and I think this is sort of cut and dry, and this is a great sort of list of compendium where you can go and sort of see what will work for your organization. What I'd also say is when you're screening for ACEs, some of the things that we talked about today really come into play. So making sure that you have a plan around follow-up, and then going back to Deb's phenomenal example of making sure that all staff involved are really aware and prepared to provide care and be welcoming to the individuals that you are providing services to. So when you're doing an ACEs screening, and for those of you who are familiar, there are some topics that could bring things up for the individual that you're asking those questions of. And so we really start talking in that instance around some of our awareness with motivational interviewing or compassionate listening, making sure that you're making that eye contact, that you're using your body language to invite someone in. Because the next step when we're talking about screenings, and I think a lot of folks on the call are already here, this is self-reported information. And unless we're creating a safe environment for a client to feel comfortable sharing the accurate answers to what we're asking, then what we're going to come away with isn't going to be helpful at the end of the day. So I think particularly when we're talking about ACEs, it's about the screenings that you're providing to adults and children. And it's also very much about how you're asking those questions and inviting people into the conversation. Because sometimes it's easier to just say, no, I haven't experienced that. And yes, I always had enough to eat. No, like I've never had a parent who was incarcerated. And no, there were no substances in my home. It's easier to protect oneself sometimes than it is to be vulnerable, especially when we acknowledge that there is sometimes a power dynamic involved with when we have someone in the room alone with a medical professional. So just want to add that sort of little asterisk on. I think that it's one of the things that we all consider when we're engaging in asking ACEs screenings. I'm not sure, Maia or Deb, if you want to add anything to that, or if you want to jump to, I think we got a great question here around acknowledging we're running out of time, but sort of are there resources where we can locate the ROI for these interventions and support our proposal to our organizations? I know I would never dream of keeping a question about ROI away from Deb and Maia.
Yeah, and so I mentioned in response that we're going to put some additional resources together. The ROI, again, is very dependent on what it is that you're doing, what screening that you're doing, that you see some sort of financial benefit, but certainly identifying acuity of a patient by incorporating both the physical health and behavioral health is where you get your ROI. You can renegotiate whole health plan contracts because now you're really speaking to their full scope of need and not just their physical scope of need. So that should give you a hint of what I'm going to perhaps share with Kirsten so that she can share it along to the rest of this group.
That email with the slides is just getting longer and longer. It's all good. It's all good. Perfect. Well, I know we have 3 minutes left. Folks can, get back to their regularly scheduled, very busy lives if you'd like, but, if someone wants to try and sneak a question in, happy to stay on the line for 3 more minutes, but just want to recognize and thank everyone who's still here for being so engaged and so interested and for being part of this field. I think we forget sometimes because of the day-to-day that we're all kind of in a car that's being built as it's being driven down the road in this integration space. And I'd like to think, we've got some doors, we've got some tires, but I think it's times like this where we realize that there's a lot of intricacies that everyone here today, you get to figure out how it's going to work best for your organization. And all of us are grateful that you're engaged and interested in doing this best practice work. It really makes a difference and it really changes and saves lives. So thank you all for your time. We don't take it for granted. I don't know, Deb, Maia, do you want to say any closing words?
I just want to say thank you. This is a fun group to present for. I love the participation, which really makes it for us. So thank you all.
Yes, I live for the chat. So thank you. Thank you.
Yes.
Yeah. Perfect. Okay. Well, thank you everyone for coming on. I think we're about at the end of our time here, but stay safe, And we look forward to seeing you next time. We'll be sending out some information probably within the next couple weeks about our third webinar. And we're hoping that we can see you again soon then. Until then, you'll get our email with the slides. Stuff will be posted to the website, and we'll be having a tip sheet from the best of hits from today's webinar featuring the honed expertise of Deb and Maia. But thank you all so much and take care.